Good afternoon, everyone. Thanks for the invitation, Dr. Goldman, and thank you for the introduction. So I'll be talking today about the epidermoid and epidermoid cysts in the region of the head and neck. I don't have any disclosures. Through this presentation, I'll go through first etiology and embryology of the development of these inclusion cysts. We review the pathologic findings, the clinical presentation, depending on the location, the role of imaging and the imaging features of both dermoid and epidermoid cysts, and then we'll review the differential diagnosis based on the location in the head and neck region. So let's start first by some embryologic etiology for the development of these cysts. So dermoid and epidermoid cysts are both ectoderm-lined inclusion cysts. They differ by complexity, however. The epidermoids have only squamous epithelium. Dermoids contain both hair, sebaceous and sweat glands, as well as squamous epithelium. They are both inclusion cysts that are monodermal. So that means they are derived from a single germ layer, as opposed to teratoma, which can have additional tissues of mesodermal or endodermal etiology. Congenital dermoid and epidermoid cysts result from an embryologic accident with failure of the surface ectoderm to separate from the underlying structures. So they might arise either when the surface ectoderm fails to separate completely from the developing neural tube, or when the surface ectoderm undergoes complex enfolding, invagination, and fusion as the ears, eyes, and face begin to form. The epidermoid cysts are thought to develop later in embryonic life than dermoid cysts, and this is because they have less complex appearance. We believe that they develop at a later stage when the cells are committed to a single cell type, as opposed to dermoid cysts, where we believe that the cells are still pluripotent and able to give like other parts of the cyst. So dermoid and epidermoid cysts may also be acquired at any age in the subcutaneous tissues, as well as in the spinal canal. And this is because of a traumatic implantation that drives skin elements from the surface into the underlying tissues. So this can be like, for example, from a traumatic spinal tap, post-surgery, for example, or from any other trauma as well. They can occur along anywhere along the craniospinal axis. Clinically, it depends on the location, but in the soft tissues, they are usually non-tender, slowly growing mass that will grow slowly over years or decades. So pathologic and histologic characteristics of dermoids, they are unilocular cysts. They will expand slowly by accumulation of the cutaneous products from the wall of the cyst. Epidermoid cysts have a thin squamous lining, and it contains debris, mostly keratin and some cholesterol. The cholesterol will derive from the breakdown of the cell membrane. Dermoid cysts have a thicker lining. They may show lipid material, which can be floating like a supernatant as oil on water above the heavier proteinaceous debris. And the lipid material in dermoid cysts result from the secretions of the sebaceous glands, as opposed of the lipid that we see in teratoma, where it's kind of derived from the mesoderm. As of imaging features, we can have like a lot of overlap between epidermoid and dermoid cysts. Both they are unilocular cysts, but dermoid tend to be more complex and variable in appearance because of its content. Epidermoid cysts tend to have density and signal on CT and MRI, respectively, parallel to that of the water. However, this can be also a little bit variable, depending on the ratio of keratin and cholesterol. So sometimes it can be slightly negative density because of some fatty content, but it's not going to be like a pure fat appearance. However, on MRI, the signal will not suppress completely on flare, so it's not like pure as water, and it tends to restrict on the fusion-weighted images. Dermoid cysts, on the other hand, they tend to have more fatty density and signal. As of the wall of the cyst, it's usually too thin for epidermoid cysts, so too thin to be seen radiologically, and only rarely we can see any calcifications of or enhancement of the wall. On the other hand, dermoid cysts, the wall is usually thicker, and this can be radiologically visible. It can either calcify and may enhance as well. But again, there's a lot of overlap between these two entities. Treatment depends on the location, can be conservative management or surgical resection. And when we have subtotal or incomplete resection, recurrence can occur, but it's uncommon. And when it occurs, it's usually delayed years after the surgery. I will start now discussing dermoid and epidermoid based on the location in the head and neck of region, starting first by the midline nasofrontal region. So when we have a midline nasofrontal mass, we have a spectrum of pathologies that can occur in this region, which have some kind of similar underlying etiology. We have the nasal encephaloceles, nasal glioma or glial heterotopia, better known as glial heterotopia, and nasal dermoids. So all of these three pathologies occur around normal points of development, and they will result from aberrant normal development process. Nasal dermal sinuses, nasal gliomas, and encephaloceles will result from incomplete regression of the projection of dura that transiently traverses the prenasal space. And we'll review this in more detail in the next slide. The most important feature of a midline nasal mass and the most important radiologic role in this setting is that it can have the potential to extend intracranially. So let's review the embryology of this region. I'm showing here the diagram by Barkovich et al. From 1991, showing like the normal process of development. So during development, we have two transient spaces that will be formed by the developing structures of the nasopharyngeal region. First, we have the fronticulus frontalis, which is a space that lies in the midline between the paired frontal and nasal bones over here. And then we have more posterior the prenasal space lying between the cartilage of the developing nasal capsule and the nasal bone. So that's early in the development. Later during the development, the fronticulus frontalis will close, and the prenasal space will become so narrow and completely surrounded by bone. And then we'll have the foramen cecum at this level. And at this point of this stage of development, we have a diverticulum of dura that extends anteroinferiorly through the foramen cecum and will transiently contact the superficial ectoderm in the region of the nose. And as development progress normally, the dura projection will retract back into the cranium, and the foramen cecum will eventually be obliterated and filled with fibrous tissue. So now let's review each entity, exactly what happens in each case. First, for the encephalocele, if the diverticulum, dura diverticulum persists, then the meninges, the developing brain, and the CSF can protrude through that diverticulum, and they will form an encephalocele. For the glial heterotopia or nasal glioma, if the dura diverticulum persists, but will become pinched off the cranial vault, so it's going to be separate of that during further development of the dura and bone, then it becomes a heterotopic focus of glial and meningeal tissue. And then at the end of the spectrum for dermoid and epidermoid cysts, if the dura diverticulum persists and becomes adherent to the ectoderm, it can pull ectodermal cells below the skin surface as it attempts to regress. And the dermal sinus tract form along the regression path of the dural diverticulum. Along the path, dermoid and epidermoid cysts can form either alone or in combination with the dermal sinus tract. So along all of this path, we can have the formation of dermoid cysts, extending even intracranially and through the foramen cecum. So nasal cephalocele at the first, as a first entity, it results, as we said, from herniation of the intracranial tissues into the dural projection. It can occur either through the foramen cecum. In this case, it can be either nasoethmoidal or nasal orbital cephalocele if it extends to the orbit, or it can occur through the fonticulus nasalis. And in this case, it's going to be called nasofrontal cephalocele. So it's going to be two different locations for a potential nasal cephalocele in this region. These patients have a higher rate of associated brain anomalies, including callosal dysgenesis, schizencephaly. And MRI is usually superior to CT for better delineation of the herniation pathway and to assess for associated intracranial anomalies. This is an example of a 7-year-old who presented with a nasal mass. And we have a sagittal T2 and post-contrast sagittal T1 weighted images, as well as a coronal CT scan. On the CT, we see a defect in the anterior base of the anterior cranial fossa at the level of the cribriform plate with widening of this region. On the MRI, we can appreciate a predominantly fluid-filled mass with some soft tissue component. And we can appreciate that there is contiguity of this soft tissue component with the intracranial content. So this represents like gliotic brain parenchyma with associated herniation of the CSF and meninges, and it's compatible with a nasal cephalocele. Nasal gliomas would be better known as nasal cerebral heterotopia. It forms like a dysplastic brain tissue within the nasal cavity or subcutaneous tissues over the glabellar region. And it's going to be separate from the intracranial contents as opposed to the encephalocele. It results from the herniation of the brain through the foramen cecum into the dura projection, but there is subsequent regression of the more crenate portion of the projection. Therefore, this will result in a sequestration of the glial tissue within the nose or nasal soft tissues. High-resolution MRI is required, or if CT, we need a CT with injection of intrathecal contrast to be able to allow the differentiation of nasal glioma versus encephalocele to demonstrate whether there is or no contiguity of the heterotopic glial tissue with the intracranial contents. The differential diagnosis is mainly like clinical hemangioma. Usually, clinically, we'll be able to tell the difference. It can present as well as a midline mass in this region, in the nasal region, but it's usually more like soft discolored mass appearance. This is an example of a nasal glial heterotopia in a 3-month-old patient who presented with a midline nasal mass. So we can appreciate a heterogeneous mass of heterogeneous T2 signal in the region of the subcutaneous soft tissues at the level of the glabella, as well as a component within the nasal region. And in this case, we can see that on T2 weighted images, we don't see any contiguity of this mass with the intracranial contents, so as opposed to encephalocele. This is sagittal T1 pre and post contrast, and we can appreciate that a component of this mass is enhancing. Now, nasal dermoid and epidermoid cysts and sinus tracts in this region, if the dura projection remains adherent to the skin, there will be a small dimple at the external surface of the nose. This dimple is the external orifice of the dermal sinus tract, and the tract can terminate anywhere along the path of the dura projection and can extend upward through the foramen cecum into the cranial vault. Dermoid and epidermoid tumors result from the desquamation of cells of the dermis and epidermis lining of the tract, and they may develop anywhere along the tract. They may extend posteriorly beneath the crista galli or anteriorly into the fonticulus nasalis. So nasal dermal sinus, they form like 11% of the head and neck dermoid cysts. The fistula can present as a fistula orifice located in the median line of the nose or median line of the face between the eyebrows and nasal columella. A second fistula sometimes can be seen in the inner region of the inner canthus. So we have to explore the region of the orbit as well. The nasal dermoid cyst presents as a round mass at the median line of the nose. And these patients can present with repeated infections. This is an example of a dermoid cyst and dermal sinus tract extending intracranially in a 6-year-old boy who presented with a nasal pit. And this is high resolution case imaging in the sagittal plane and post-contrast sagittal T1 weighted images. We can appreciate T2 heterogeneous mass in the floor of the anterior cranial fossa behind the crista galli. And this mass is, there's no solid enhancement, there's just a very thin rim of peripheral enhancement. On axial diffusion weighted images, we see some corresponding diffusion restriction, and this is the appearance on T2. So that was a dermoid cyst extending intracranially. This is an example of a patient who presented initially at 6 months of age, and this is the pre-op CT scan. So they had a mass at the level of the nasal tip, which is like more fatty density, corresponding to dermoid cysts. And we don't really appreciate much like as of intracranial component at this point. Note that this is a CT, and it will be hard to tell if there is any intracranial component based on this only. There might be some widening of the foramen cecum, although this as well at this age can be somehow hard to tell. So this patient underwent resection at the 8 months of age of the nasal tip lesion. And then they presented later with concern for recurrence and intracranial extension. So this is an MRI that was done at 12 months of age. And you can appreciate at the level just above the foramen cecum, this mass that is T1 hypointense with some intrinsic T1 shortening, reflecting fatty signal. And it's more dark on T2. And you can appreciate corresponding diffusion restriction. So this patient actually has like an intracranial component that requires resection as well. This is an example of a 2-year-old who presented with a lump in the nasal region. And you can appreciate in the region of the glabella, in the subcutaneous soft tissues, a mass that is T2 hyperintense. But additionally, in the region of the nasal bone and extending to the foramen cecum, we have an additional lesion that has similar signal characteristics, T2 hyperintense with thin rim of enhancement corresponding to a deep extension of the nasal dermoid. And we can appreciate some widening of the foramen cecum at this level. As a findings that you can appreciate with these midline nasofrontal masses, first, of course, we can visualize the mass itself. Most importantly, we have to evaluate for contiguity with an intracranial component. Other findings would be widening of the nasal septum, widening of the foramen cecum, maybe on CT as well, some distortion or bifid appearance of the crista galli. We can see bony defect in the cribriform plate and widening of the interorbital distance. And these class 2 are mostly seen with cases of encephaloceles mainly. There are some pitfalls for the evaluation of this region on imaging. First, we have normal widening of the inferior nasal septum, approximately 5 to 10 millimeter, posterior to the junction with the nasal bridge. So this should not be confused with abnormal widening associated with these abnormalities. Then during, just prior to pneumatization, we can have some fatty changes in the inferior frontal sinuses, which can be mistaken as a dermoid sinus, dermoid cyst with fatty content. But usually these fatty changes will be separated by a septum between the pneumatizing spaces as opposed to a dermoid cyst, in which case we will not have a septum. And then most importantly, the most important pitfall is the fatty changes that normally will occur in the crista galli or perpendicular plate of the ethmoid. So normally this begins around 12 months of age and starts posteriorly and inferiorly and progresses anteriorly and superiorly. So it's important not to overcall this as a dermoid cyst. So for these masses, the main role of imaging is to assess for intracranial extension. If we don't have intracranial disease, the surgery usually consists of exposing and removing the sinus tract. If there is a tract that extends upward through the foramen cecum, but there is no intracranial tumor, many surgeons will only tie off the tract at the skull base. However, if there is an intracranial tumor, there will be combined intracranial and extracranial approach to remove the entire dermal sinus. Therefore, it is very important to assess the full extent of the dermoid or epidermoid tumor, but it's less important to determine whether the sinus tract extends intracranially. It's more important to really check if there is a component rather than just extension of the sinus tract. Treatment is usually surgical, and surgical methods for removal of the dermoid sinus and cyst should meet the following requirements. There should be optimal access for complete removal of the cyst, fistula, and diseased bone tissue. The surgeon will be able to repair the skull base and stop any CSF leakage, and it should promote nasal reconstruction and post-op cosmesis. So now moving to another common location where we can see dermoid and epidermoid in the head and neck is the orbit. In the orbital region, dermoid and epidermoid inclusion cysts are most commonly arise near the developing sutures of the orbital bones. So they occur in some specific expected locations, usually around the zygomatico-frontal or frontoethmoidal sutures. They will grow slowly and often become apparent in the first decade of life. Most of them manifest as a painless mass and are commonly superficial. However, the deeper lesions sometimes will be not identified and just incidentally found, or if they are large, they can manifest as proptosis. More than 80% of orbital dermoid inclusion cysts occur in the upper outer quadrant of the orbits or in the lacrimal fossa. They can be either within the bone or within the soft tissues of the orbits. Dermoid inclusion cysts may rupture spontaneously or following trauma. And in this case, there will be intense inflammatory response in the surrounding tissues, which can mimic orbital cellulitis or even an aggressive tumor. On imaging, both dermoid and epidermoid inclusion cysts will slowly expand over time, producing an indolent periosteal and intradiploic remodeling of the bone, which usually manifests with a reactive sclerotic rim. Therefore, they typically appear on radiographs or CT as a sharply delineated lucent lesion with a dense surrounding rim of bone. They will typically appear as a well-circumscribed unilocular cystic masses. Epidermoid inclusion cysts are usually very similar in appearance to water on CT and MRI, as we already saw. Sometimes the attenuation is slightly higher than water or CSF, and the signal will not suppress on flare, and they usually restrict diffusion. Most dermoid inclusion cysts have attenuation and signals similar to lipid. The content or the central portion of the cyst will not enhance, but they often have a discernible wall that can enhance and can show even calcifications. This is an example of a dermoid cyst in the upper outer region of the orbit, which is the most common location in this area. In a 19-month-old male who presented with a mass in this region that was growing in size since birth. So on the soft tissues, the soft tissue kernel, we can appreciate a well-circumscribed lesion of fluid density in the center with a thin wall. And we can see associated osseous remodeling and lytic changes with a thin sclerotic rim. Additionally, we can appreciate in this region a tract that is extending toward the superlateral portion of the orbit. This is another example of a dermoid cyst in the orbital region in a 10-year-old patient who presented with a mass. So we have a coronal T1, and then we have a post-contrast T1 fat-satted images. So we can appreciate a well-circumscribed mass with heterogeneous signal on T1 and some areas of intrinsic T1 shortening that suppress on fat-satted images corresponding to some fatty component. Additionally, we can see a rim peripheral wall, enhancing wall. On T2, the appearance is heterogeneous as well due to some fatty component that is suppressed on fat-sat. This lesion demonstrates restricted diffusion, and there is some associated osseous remodeling with a benign appearance. So all of these features are compatible with orbital dermoid cyst. The differential diagnosis in this region includes encephaloceles, but these usually occur more in a medial location in the frontal orbital region near the midline. They will have some content that is CSF-like, and there is associated abnormalities such as defect that will be contiguous with the anterior cranial fossa. Other differential diagnoses, but usually these are more easy to differentiate from dermoid or epidermoid, except if there is like inflammatory changes from rupture, include fibroosseous lesions, Langerhans cell histiocytosis, neuroblastoma metastasis, and granulocytic sarcoma. Now switching to floor of mouth lesions. So dermoid and epidermoid cysts in the floor of mouth, they will typically present as a unilocular mass, thin-walled. They can be located either in the submandibular or sublingual space. Again, dermoid cysts will be low density, unilocular, well circumscribed mass on non-contrast CT. They can show fat or mixed density fluid and calcification. They can have the appearance of sack of marbles, appearance due to like the fat droplets that they coalesce together to form this appearance. And they may show a rim of contrast enhancement. Epidermoid cysts will be also unilocular, but more fluid density or signal, and usually the wall will be imperceptible. This is an example of a dermoid cyst in an 11-year-old patient who presented with a submental swelling. And we can appreciate this lesion that is well circumscribed, showing T2 hyperintense and T1 hypointense signal and restricting diffusion. This lesion was located in the sublingual space deep to the mylohyoid sling. One important differential in this location would be ranula, which is a retention cyst from the sublingual gland or from the minor salivary gland. It occurs secondary to ductal obstruction, either from a trauma or prior infection or inflammation. And ranula can be either a simple ranula when it is confined to the sublingual space, or it can be diving when it extends to the submandibular space. Simple ranula will present as a unilocular cystic lesion, which lies usually lateral to the genioglossus muscle. So usually it's just on one side of the floor of mouth. And it will lie deep to the mylohyoid muscle, which means above the mylohyoid muscle. Rarely, they can dissect across the midline and extend to the other side. Diving ranula, the bulk of the mass itself is mainly in the submandibular region, so it can be inferior to the mylohyoid muscle. But one thing to look at in these cases, and can be helpful to differentiate ranula from other lesions in the submandibular space, is the presence of a small beak that will extend to the sublingual region, given that it arises from the sublingual region. And this is called tail sign. On imaging, ranula will have fluid density on CT. If they become infected, they will show thick, irregular rim of enhancement with some surrounding inflammatory changes. On MRI, it will show as well fluid signal with low T1, high T2 signal, but depending on its content, if there is high protein content, we can have more higher T1 signal. And this is an example of a ranula in a 13-year-old who presented with a submental mass. So we can see this well circumscribed lesion of fluid signal, T2 hyperintense and T1 hypointense. And we see it's confined to the one side. And this is the region of the genioglossus muscle over here. And it's above the mylohyoid muscle. So it's in the sublingual space. So this is a simple ranula, not a diving type ranula. Another differential diagnosis is a lymphatic malformation, which is a transspatial, infiltrative, multiloculated cystic lesion. On CT, it presents as a hypodense mass with fluid attenuation, but we can see higher density if it is infected or hemorrhagic. On MRI, it demonstrates low or intermediate T1 signal and hyperintensity T2 signal, but we can see some T1 hyperintensity if there is hemorrhagic or lipid content, and we can even see like fluid levels as well with hemorrhagic content. This is an example of a lymphatic malformation in this 13-year-old patient with a neck mass, and this lesion was located in the submandibular region inferior to the mylohyoid muscle. Next, we'll talk about dermoid and epidermoid cysts that can occur in the skull and scalp. So dermoid and epidermoid cysts are among the most common pediatric skull tumors. They can occur either in the soft tissues or in the skull itself. So epidermoid cysts in the skull, when they are within the tubuli, they can occur in any part of the skull, but most commonly they occur laterally in the parietal or frontal bones. And they are usually discovered at a later age during early adulthood between 20 and 50 years of age. On CT, they appear as well-demarcated intradiploic osteolytic lesions with smooth sclerotic margins. And often they cause remodeling and expansion of the inner and outer tables. On MRI, they will have fluid signal on T1 and T2 weighted images, but again, they tend to restrict diffusion and usually do not show enhancement. Dermoid cysts in this region tend to occur at an earlier age, usually during the first 3 decades of life. They typically occur in the midline, like near the region of the anterior fontanelle. On CT, they will appear as expansile lytic lesions in the midline. They can extend to the adjacent soft tissues or can extend intracranially. They tend to show some fat attenuation, and we can see some wall calcifications. On MRI, we have a more heterogeneous appearance, but we can see again restricted diffusion and some thick peripheral enhancement. This is an example of a patient who had epidermoid cyst in the right occipital calvarium, and we can see a well-circumscribed lytic lesion with a sclerotic rim in the right aspect of the occipital bone, and this lesion demonstrates more like a fluid density. In this case, there was no extension intracranial. This is an example of a dermoid cyst. So as we said, dermoid cysts tend to occur more in the midline and most commonly in the region of the anterior fontanelle, as we can see on, at this level on the sagittal T1 and KISS imaging. And there is corresponding restricted diffusion. In this case, there is no intracranial extension. Differential diagnosis for like these lytic skull lesions or scalp lesions as well include leptomeningeal cysts, also known as growing skull fracture, atretic cephalocele. Atretic cephalocele is like a skin-covered midline scalp mass that will be contiguous with meninges and degenerated brain tissue and is connected intracranially to the dura by a fiber stalk. They can be associated with a persistent falcine vein, and they most commonly occur in the parietal location. Langerhans histiocytosis is one of the differential as well as a lytic lesion with beveled edges. It has variable signal, but not in LCH. We tend to have more marrow edema, and usually there is an enhancing soft tissue component associated. Another differential is parietal foramina and sinus pericrani, which is a vascular anomaly in which we have communication between the extracranial varicosities and the dural venous sinus through diploic veins. And sinus pericrani tend to like change in size with changes in intracranial pressure. This is an example of a leptomeningeal cyst or growing skull fracture. So this is a child that presented initially with a depressed left parietal fracture after a fall. And years later, this fracture has widened, and there was associated like herniation of the CSF and the gliotic brain parenchyma. And this is an example of an atretic parietal cephalocele in this newborn who had a midline scalp soft tissue mass, which contains a fluid component and some soft tissue component that is enhancing. Note how this is contiguous with a fluid-filled tract with the intracranial component, and note the associated persistent falcine vein instead of a straight sinus. Now moving to the intracranial dermoid and epidermoids. They are rare. They form only less than 1% of all intracranial masses. They are usually diagnosed later, like in the third decade. And the clinical presentation can be variable. They can be completely incidental, or they can present with headache, seizures, mass effective large, aseptic meningitis if they rupture, infection, especially with dermoid cysts associated with a dermal sinus tract. And we can even have transient cerebral ischemia from vasospasm in case of ruptured dermoid cyst with the fat droplets extending into the subarachnoid spaces. As for the location, dermoid cysts have a predilection to occur in the midline, and they are often associated with the sinus tract and in the occipital region. Epidermoid cysts tend to be more off the midline, lateral in position, with the main locations in the CP angle or in the paracellular cistern. Dermoid cysts tend to present earlier in life than epidermoid cysts, and this is probably due to their midline location, which can interfere with the CSF circulation, and to their association with dermal sinus tract, which predispose them to infection. Management is surgical resection, and if resection is partial or subtotal, recurrence may occur with typically long interval after surgery. This is an example of an epidermoid cyst with occipital dermal sinus tract. So the pathology in this case turned out to be epidermoid, although it looks very similar to a dermoid, given that it is midline location and has some fat density and signal. So this lesion has a midline location in the cerebellar vermis. There was an associated thin tract through the occipital bone. And note the lamellated appearance on T2 weighted images. And there was some surrounding vasogenic edema because this was an infected epidermoid cyst. There is some corresponding restricted diffusion, some intrinsic T1 shortening, reflecting some fatty component, and there was a thin wall, enhancing wall. As well, we can appreciate, like on the post-contrast images, that tracked through the occipital bone. This is an example of another patient who had a dermoid cyst in the occipital region with wide dermal sinus tracts. So this lesion was extra-axial, posterior to the cerebellar vermis and causing some mass effect. And you can appreciate the wide dermal sinus tract through the occipital calvarium. We have an enhancing wall, corresponding restricted diffusion, and some heterogeneous signal on T2. So that was it. So the embryologic etiology explains why these lesions occur in certain typical locations, like superlateral orbit, midline near the anterior fontanelle, or like the midline nasofrontal region. We reviewed the imaging features and the differential by location. And most important role of imaging in dermoid and epidermoid cysts of the head and neck is looking for intracranial extension. And these are my references.
Thank you so much. That was incredible. Very so comprehensive. Definitely something that we see not infrequently, and something that comes up is always the differential diagnoses. If anybody has any questions, feel free to put them into the chats or the questions. Susan says, "Awesome job." I don't know. Do you have a specific imaging protocol for the nasal masses, for like an anterior nasal mass, or just kind of use your routine face protocol, or do you have a specific one?
No, we have a specific one that includes KISS imaging, most importantly, to look for the tract and intracranial extension.
Yeah, so maybe anybody has any other questions, feel free to put them into the chat.
Okay. Thank you, Adam, for the invitation again. It was a pleasure for me to be here.
Thank you so much, and incredible talk. And yeah, see everybody. Hope everybody has a nice, great holiday, and see you everybody in the new year.
Thank you. Bye.